the next joint awardee of AIOS Siva Reddy International Award. And this is none other than my very close friend, Dr. George V. Puthuran. He is the man behind the RD wall, and he's going to talk on evolution and widespread use of an affordable aqueous drainage implant. So over to you, George.
Thank you, Amit, and thank you, AIOS Scientific Committee, for this huge honor. I am humbled, but also I'm feeling very proud to deliver this lecture. I have no financial interest in the subject matter of this talk. So affordability, prohibitive cost was the main deterrent for uptake of tube surgeries in the developing world. And there were two professors, Professor Paul Palmberg from the Bascom Palmer Eye Institute in Miami and Professor Alan Robin from the Wilma Eye Institute in Baltimore. Both of them were very passionate about providing a non-valved bowel glaucoma drainage device to the developing world, for the portions of the world that could not afford to pay 60,000 Indian rupees per device. Unfortunately, they were not able to convince various companies that owned the bowel glaucoma implant at that time to do so. Professor Alan Robin has been a one-man army guiding the Aravind glaucoma services right from its inception, and I'm extremely proud and privileged to have a much older version of Professor Robin here in the audience today. And I know for sure that Professor Palmberg and Professor Robin had absolutely no difficulty in convincing Professor George Barwell to allow Orolab to use this design which he had bequeathed to the glaucoma community. So Orolab aqueous drainage implant is an affordable version of the 350 square millimeter Barwell glaucoma implant. So reverse engineering the design was not difficult for Orolab. But to cut a very long story short, Orolab had to innovate with cost-effective manufacturing. Liquid silicone rubber molding, which was used for the Barwell glaucoma implant, would have involved lot of investments in terms of machineries and overhead costs. Orolab innovated to use a simple compression molding process, but the difficult part was to identify compression moldable medical grade silicone. The process, which started in 2005, culminated in its launch in 2011 in the Tamil month of Adi. And this, in the Tamil calendar, the month of Adi is supposed to be auspicious, and it's also coincidentally the month where good products are available at highly subsidized rates. We were fortunate to have Professor Palmberg with us for the launch. He also made a couple of other visits after that to train surgeons at various Aravind Eye hospitals. Now it was our turn to train and teach. The concept of the non-valve device was a little new, and it was an absolute joy to spend hours late after hospital hours for almost 6 months to develop an animation to simplify the principle and surgical technique of this non-valve device. I used to pounce on every opportunity I got in the early part of the last decade to try and make surgeons comfortable using this non-valve device. Later on, I was fortunate enough to volunteer my time for Orbis International, and I thought the hospital-based training programs of Orbis International was an excellent platform for me to reach out to so many young surgeons in reputed institutes across India. Multiple awards followed with our work on the RD. At the World Glaucoma Congress in 2013, a couple of times at the American Glaucoma Society annual meeting, and also at the annual conference of the Glaucoma Society of India. The work with this affordable device again made to the cover of multiple issues of Journal of Glaucoma, and also the results, our initial results of the RD with in adult refractory glaucoma was our first publication about the Orolab aqueous drainage implant, appeared in Ophthalmology Glaucoma. Very soon we had this publication in pediatric refractory glaucoma, our experience of the RD in pediatric refractory glaucoma in BJO, and thankfully both these publications were, the results were more than comparable to the initial results in literature with the Molteno, Barwell or the Ahmed glaucoma valve. So by the late 2015, we started burying tubes in the patient's own sclera. This is a 23 gauge needle generated 4 millimeter long scleral tract for tube insertion, and we soon realized the conjunctival healing over the tube insertion sites had to be seen to be believed. I consider this work, which was published in the American Journal of Ophthalmology, as most important in my career. Some of the modifications we did, where to place the tube so that there is minimal contact with the upper eyelid, how to make how to make available an optimal length of 2 millimeter, which is neither too long, too short. All this and much more has been beautifully described in this paper. Most importantly, the dreaded complication of tube exposures and tube extrusions in the pediatric age group to a large extent was taken out of the picture. We also looked at, there were some practice pattern changes also along the way. We looked at our preferred second quadrant of choice of conjunctiva for tube insertion. We used to do a lot of infranasal tubes, but we soon realized even though infranasal tubes are doing as well as the supratemporal tubes in the adult refractory glaucoma, the safety and efficacy were being compromised, and now supranasal quadrant is our go-to quadrant for if you need to, for any reason, need to repeat the GDD. We have also published on RD as primary surgical intervention in multiple secondary glaucomas, in iridocorneal endothelial syndrome in Graffe, again neovascular glaucoma in BJO, and also outcomes of RD in aniridia associated with glaucoma in AJO. It was an absolute joy once again to work closely with our vitreoretinal colleagues in select situations of refractory glaucoma, where we did and we published our results on pars plana tube insertion. We looked at various complications of this non-valve device, outcomes, incidence and outcomes of retinal detachment surgery, hypertensive phase. We had evidence. There's not much of literature on hypertensive phase in non-valved implants, and we could answer so many questions from fellow glaucoma surgeons with evidence after this publication came up. We looked at incidence and outcomes of suprachoroidal hemorrhage following RD, and again, early and late hypotony following non-valve device was another major deterrent to the uptake of tube surgeries. This was again another opportunity to work closely with Orolab. We could come out with the 3-0 multifilament nylon. Every non-valve device now gets the supralaunch suture intraoperatively. It's made surgery so much more safer. We have the RD250 available, and I can vouch for the fact that these are all products that have been brought out by Orolab with very little business interest in mind. They are absolutely a social commitment to the community. Again, another publication which gave us a lot of satisfaction, we found that eyes with pre-existing RD, subsequent to phacoemulsification, still had good control of intraocular pressure, and thankfully long-term surgical outcomes are also very encouraging. It all started with affordability, but I tell you it's now more of, it's also about efficacy. We see larger surface area, thinner wall, low profile blebs, whereas bleb encapsulation and tenon cysts continue to be a problem with valved implants. I would like to mention just 5 individuals here. My mother, who is an ophthalmologist, father was an ophthalmologist, Padma Shri Dr. G. Nachiyar, who is my mentor in ophthalmology, my grandfather, who was also an ophthalmologist, who is a contemporary of Dr. P. Siva Reddy, and my mentor in glaucoma, Dr. Krishna Das. I'm grateful for my mentors and colleagues at Aravind Madurai, and more than Professor Robin was already a family. Professor Palmberg also became family, and more than a decade and a half, I used to wonder why these much acclaimed super specialists would want to make multiple visits to our part of the world. It took me a good part of 10 years to realize these American Academy of Ophthalmology's outstanding humanitarians were working tirelessly to improve eye care worldwide. And it was truly my privilege to play a vital part in the evolution and widespread use of this non-valved implant. I am so proud that some of the initial lives that were touched were in some of the most remote parts of Tamil Nadu. I truly believe this implant is preserving useful vision in so many patients and will continue to do so. I will leave you with just one email that I received from Professor Paul Palmberg. This was after the American Glaucoma Society meeting last year, where he talks about how blessed he was with the gift of, and he was thanking his trainees for allowing him the gift of being part of their career, and he ends by saying, as I said there, my wish and prayer is that at the end of our careers and lives, that we will hear a voice saying, well done, good and faithful servant. Thank you so much.
Thank you, George. It was really emotional and and seeing all the photographs and mentors there in the last few slides, it is an